Hello, welcome back everybody to our last session of the day. I'm looking forward to this talk. I'm going to introduce Mr. Max Mifsud. He is a consultant in trauma and orthopedic surgeon at the Oxford University Hospitals. He also practices at the Nuffield Orthopedic Centre. He has got a truly international presence. He's done a fellowship in the Paediatric Orthopedics and Bone Infection in Oxford and at the Nuffield Orthopedic Centre, in sarcoma and joint reconstruction in London at the Royal National Orthopedic Hospital there, and then hip preservation in Bern, Switzerland, and also a clinical research fellowship in Toronto in the Hospital for Sick Children there. I know of his work, but I've not met him. He has several publications related to paediatric bone and joint infection and has presented internationally at conferences such as the Oxford Bone Infection Conference. Welcome, Max. I've not met you, but I know your work.
Thank you very much. It's a pleasure to be here.
Lovely. We've had a really interesting discussion and day so far about. I don't know if you listened in about testing and clinical decision making and how that all comes into play and what tests are available, what tests are on the horizon, and is it going to be easier or harder in our jobs? And I'm looking forward to hearing all about that in context to pediatric orthopedic infections. So take it away, Max.
Thank you very much for inviting me. I'm more than delighted to be here. So yes, as you said, my name is Max. I'm one of the paediatric orthopedic consultants in Oxford, and a big part of my work is on bone and joint infection. I'll try to take you through some of the orthopedic aspects of that, and I'll just talk a bit about the diagnostic approach from a kind of orthopedic point of view, looking at clinical and serological, and obviously the radiological, which is a big part of our workup because it helps guide our surgical treatment. We'll talk a bit about how the classification systems used in the treatments, and also I will present a couple of case examples. As has been said, obviously these are often very difficult problems, especially if you do have a bone or joint problem. So as always, patient and family-centered care is really important. And certainly in our centre, we have a very strong focus on having ambulatory antibiotics as much as possible, which is better for everyone involved. And we also tend to follow them up, in the longer term, because we know there can be long-term problems, in particular if the growth plate is affected. And although mortality is thankfully exceptionally rare, it is one of the known problems if you have a severe bone or joint infection. And we can see changes here, obviously in the joint, but also a big dotted line with the actual growth plate, which is what we look at a lot as pediatric orthopedic surgeons. I won't go too much into this, but broadly speaking, osteomyelitis is obviously the infection of the bone, and it typically starts in the metaphyseal area because there's a high blood supply there, but it can spread into the joints, into the periosteum and into the soft tissues around that. The incidence varies from place to place, but broadly speaking, it can range from anything from 1 to 13 in 100,000 to much higher in the developing countries, and as has been touched upon before, obviously if you're immunocompromised or you have certain other conditions like sickle cell disease or chronic illnesses, you can be more predisposed to this. Septic arthritis is obviously another aspect of this. It can be a completely separate entity, but we know that the joint is damaged in two ways. Number one is the actual bacteria in the joint can damage a very delicate lining known as the articular cartilage. And if you happen to have any metalwork in that area, then you can form biofilm on metalwork, also biofilm on the actual joint lining itself. And that can be very difficult to treat. But also, and importantly, there is damage from the inflammatory response. So even if you've treated the infection, but there's ongoing inflammatory changes, that can damage the joint, and that is really important in the longer term as well. And we know that cartilage degradation and joint destruction is one of the consequences of septic arthritis. Again, the incidence is similar to that of osteomyelitis, with younger children being more affected, and boys typically more affected than girls, but we don't really know why. From a microbiology point of view, again, it has been said, there are certain bugs which are typically the causative agents, with Staphylococcus aureus being one of the most common bugs, followed by streptococcal organisms. But also there are some of the rarer bugs like Salmonella, especially in sickle cell patients. And we are now more and more aware of bugs like Kingella. And we now suspect that a lot of joint infections which were previously put down to as transient synovitis were probably a low-grade Kingella infection. And this is where PCR and things like BioFire has become really, really important. In most centres, certainly in ours, the use of PCR is growing, and it allows not only rapid diagnostics, but therefore rapid treatment, especially in centres like most of the main paediatric hospitals in the UK and certainly around the world, where there is easy or easy-ish access to image-guided aspirations of joints. And certainly in our practice, we try to get image-guided aspiration of joints within 8 to 12 hours of presentation with rapid PCR testing to guide treatments. Worryingly, there's an increase in MRSA cases, and of course, we know that certain strains of MRSA, like PBL, can cause even more damage than more standard variants. Clinical findings vary. Children rarely present nowadays with hot red joints like this, but they typically tend to present more with this sort of picture, where you've got a hip or a knee, because they are typically the joints which are affected, which are held in the position of comfort. There's often a very indolent or subacute presentation, and often, especially the very young, have very minimal symptoms initially because their ability to mount a proper immune response is less well developed. From an orthopedic point of view, what we look at is not only the joint, of course, but we're trying to assess which of the muscle compartments are affected, whether there's myositis as well. And the clinical symptoms that we look for often are things like pain, swelling, limp, fever, of course, and reduced joint movement. And I think in particular with septic arthritis, the cardinal investigation is the inability to fully extend the joint. So we know that there are certain positions at which the joint and the capsule are most lax and most capacious, and can therefore accommodate inflamed synovium and fluid in the joint. And that's typically at about 30 degrees of flexion, both for the knee and the hip, for example, and even the ankle. And so children will typically hold that joint in that position because that's the position which is least painful. And that is one of the cardinal signs in our clinical examination. From a workup point of view, obviously blood tests are standard, but we look in particular at the CRP because in acute infections, that is what's going to rise very rapidly. Synovial fluid analysis, as I said, is really important. Obviously, there are the more traditional and standard investigations, things like the white cell count, the glucose levels, the differential count, and all that. And we used to rely a lot on gram stains before, but nowadays we know that there is a low negative predictive value for these tests. And so we don't really tend to use this anymore. Of course, formal culture and sensitivity testing is important, but PCR has really revolutionized the diagnosis of septic arthritis and how we treat this. Once treatment has been instituted, whether it's medical alone or medical and surgical, the trend on the CRP is something that as orthopedic surgeons we look at. So we know that with osteomyelitis and myositis, your starting point is typically much higher because your infection is in a highly vascular bit of the body, like the bone metaphysis or the muscles around it, whereas a joint is largely extravascular, and therefore it can take longer for the CRP to rise. And if it does so, it tends to rise to a lower level than it would if it were an osteomyelitis or myositis. But then the rate at which it drops is really important. And typically we want to see a drop of about 50% every 48 to 72 hours, meaning if my CRP is 100 today and I'm started on treatment, and today is Thursday, on Saturday it should be around 50 if things are working well. Plain radiographs can be of use in the early stages. They typically are not, so we tend to use them much more for chronic infections like these very impressive images you can see on the right here, where there are various areas of bony destruction, even bony discontinuity in the tibia there. There are changes around the growth plate, but reassuringly, you can see that what is known as the highest growth arrest line, as marked out by the asterisks there, can give you a estimated timeline of how long this has been happening, because we know how rapidly those physes grow on a per year basis. But also, more importantly, they are very prognostically important with regards to knowing whether the chance of having a growth arrest or an angular growth arrest is likely to happen as a consequence of this infection. Ultrasound is really important, and we use it often as a first-line investigation, and certainly in our center as often therapeutic as well, because if there is an effusion in a joint or a collection around the bone, it will be drained under ultrasound guidance with the awake patient, and that allows us to get rapid samples to send off for microbiology. MRI, of course, is the treatment of choice, especially if you're suspecting both bone and joint infections. And we look not only at the T2s, which are often the ones where it oversells it, and you can look, it lights up in bright white where the problem is. There are certain implications from a surgical point of view, like you can see on the far images, the axial images on the right, where you can see where the intramedullary collection is exiting through a cloaca and forming a soft tissue collection further down the leg. But also the T1 images, as you can see on the far left, are really important because it tells me which bit of bone is viable and non-viable and where there is sequestrum. For the chronic infections, we use a Cerny Major classification. That is probably not particularly relevant for this talk, but certainly as you go from 1 to 4, they become more serious. Luckily, most children have type 1, which is a purely medullary osteomyelitis, and the vast majority of cases can be treated medically with antibiotics only. If you have a 2, 3, or 4, with 3 being the second most common, then you are likely to need some form of surgical treatment. As always, the management, like most of these complex conditions, is multidisciplinary. And whilst, as orthopedic surgeons, I think that we often do get involved, I'm under no illusions. We are not the heroes here. It's our microbiologists, pediatricians, and infectious diseases colleagues that are treating this. And antibiotic therapy is the cornerstone of treatment here. And it should be started promptly, if needs be, even before we have positive cultures. Using local guidelines is really important. And I think whilst traditionally there was a strong focus on IV, nowadays we tend to use oral antibiotics much more. And I know there was meant to be another talk by one of my colleagues, Stefan, who I work with very closely, one of our PEDS ID consultant colleagues, who unfortunately couldn't be with us. But I asked him for one slide, and what are the commandments as far as he's concerned in pediatric bone and joint infections. And their focus is always about using the narrowest spectrum of antibiotic possible, using it for the shortest effective time, and switching early to orals and using orals as much as possible, and always going for the highest dose. And broadly speaking, if they're less than 5, we use cefazolin very often, mostly because it tastes very good apparently and kids like it. And if they're older than 5, we tend to go for flucloxacillin. And this is some more information there. And as you can see here, the most important thing is it tastes nice and works very well. And of course, from our point of view, the bioavailability is very high. The management of septic arthritis and osteomyelitis varies from case to case. But again, traditionally, people would rush in to wash these joints out. But whilst decompressing the joint is really important, it does not necessarily need to be done with surgery. And I think there is an increasingly valuable role of interventional radiology. With osteomyelitis, it varies on the severity of the bone infection, and I'll discuss it briefly later on with some cases. But broadly speaking, with septic arthritis, often, as you can see here on ultrasound, you can see this is a knee showing a large effusion anterior to the knee with both inflamed synovium and an effusion. If you have a large effusion, then you need to take away that fluid, because as we said at the start of the talk, the combination of the bacteria within the joint, but also the inflammatory response, can damage the joint. However, the synovitis is treated with antibiotics rather than with surgery. Surgery treats fluid, not synovitis. And this is why there's an increasing role for interventional radiology and image-guided drainage of these joints. And we know that we can achieve aspiration to dryness, especially in the early stages of a native joint infection. And this is often all that that child will need to treat that. It will allow us to get a diagnosis, especially with PCR and then by formal cultures and sensitivities, and it tends to be very well tolerated. And invariably for smaller joints like the ankle and the wrist, this is the way forward, and the morbidity of the surgery is often difficult to justify if you have a good image-guided drainage service. With regards to treating the osteomyelitis, that is a bit more complex, but again, antibiotics are absolutely key, and any surgery will fail without antibiotics. But broadly speaking, the principles are about debriding the bone properly, keeping the new bone called the involucrum, which is formed, but removing any dead bone, which is sequestrum, treating any bone defects that there are, and the use of local antibiotics is absolutely key. So we use things like pastes and ceramics, which are impregnated with high dose of antibiotics, and of course, stabilizing the bone, because if you don't have bony stability with a high strain environment and the bone moving, then that allows the bacteria to flourish. If the infection involves a joint, immobilizing that joint is not a good idea, and you want to mobilize that joint well, because we know that mobilization of the joint nourishes the articular cartilage and helps it heal. Local antibiotics, as I said, are key, and I'll touch briefly on them, but generally we use calcium sulfate and hydroxyapatite composites impregnated with high doses of antibiotics, typically vancomycin and gentamicin, and they deliver a very high dose of antibiotics locally. And we know that in adults, although we don't yet know this for children, but in adults, there is evidence from large national trials that local antibiotics with a good bony debridement in chronic osteomyelitis is likely to be sufficient, and that you don't need any systemic antibiotics. We don't yet know that for sure in children, and I think it will take some time before we get there, but certainly they play a really important part. The management varies. Often, if it is only medullary, as is often the case in children, antibiotics are often sufficient, and we only really need to intervene surgically if, as you can see on the MRI here on the right, there's a large collection. And again, even then, if you can drain that under image guidance, then you might get away without surgery. If you have localized osteomyelitis, then you will need more intensive surgery. And the various techniques which we use, which I think are probably beyond the remit of this talk, but broadly speaking, the key is debriding until you're more than happy that all the infected and dead bone is gone, and then stabilizing the bone any way you need to allow it to heal. I'll give you one case example here. So this was a young lad who had a chronic osteomyelitis of his humerus, which was rapidly developing. You can see in August he had a relatively normal x-ray. By September, there were extensive bony changes, and 2 weeks later, he suffered a pathological fracture through this infected bone. This was sampled, and we found out what the bug was. This was a typical Staph aureus case, and then went on to have bony debridement. You can see all the periosteal reaction there, where the bone has been trying to heal around the infection. And this instrument here is marking what's known as a cloaca, where there is pus exiting from the bone. But what we want to keep is we want to keep the new bone, the involucrum, and take away all the sequestrum. The debridement is often very extensive, involving a combination of tools, which I'm sure looks very impressive and probably somewhat gruesome, but we are very aggressive with our debridement of the bone to make sure that we take away as much of the dead and infected bone as possible, and the various techniques we use to minimize the damage that we cause through the surgery itself. As I said, the MRI is really important to look for these hidden channels where bugs can hide, nooks and crannies, and we actively search for them based on the MRI and treat them. And then the key is local antibiotics. As you can see here, these are beads coated with high dose of antibiotics, as well as a paste, which you can see in the x-ray there, with, of course, good soft tissue coverage afterwards. And this boy went on to heal very well and is now back to using his arm entirely normally, with the residual changes seen on MRI purely post-surgical changes. Sometimes cases can be very complex with a combination of septic arthritis and osteomyelitis. And again, early mobilization is key here. This was a girl who had bilateral septic hip joints, which unfortunately underwent several washouts, which failed to sufficiently treat the infection because of the osteomyelitis elements. She unfortunately eventually went on to suffer a pathological fracture of the hip as a consequence of the infection. You can see that here, and you can see there are extensive bony changes in the right hip. So she had a combination of septic arthritis and osteomyelitis, which was initially treated non-operatively, but this unfortunately failed. She then had one type of surgery to try to realign the bone, and she was eventually referred to our center, where she underwent, she had a CT scan which showed that she still had the fracture despite this being months down the line. There was still an active effusion, still extensive bony changes. So we went on to formally debride the bone, perform an operation known as a surgical dislocation of the hip, put local antibiotics in, fix the head back on, and undid the previous bony surgery she had. And she went on to do very well with early mobilization of the hip, antibiotics systemically and locally. And now she's back to doing her ballet, mum dance, and cycling. And we can see that the femoral head is growing nicely. Finally, growth plates injuries are really significant, or can be very significant. And I talked earlier on about something known as the Harris growth arrest line, which is a line that the bone develops, hopefully parallel to the growth plate, and a bit like the rings on the trunk of a tree. We can not only time the infection, but also we can get more information about whether the child is likely to have a length or an angular growth arrest as a consequence of their infection. And broadly speaking, we tend to follow these children up for at least a couple of years after they are clear of their infection, if not skeletal maturity, depending on what the case was. And if the differences are small in length, we just tend to observe them, or maybe treat them with relatively minor operations like epiphysiodesis, which is slowing down the other leg. And if they are larger differences, then we sometimes need to formally lengthen the limb or shorten the other one. I think in summary, the key points are, from a diagnostic point of view, the range of movement on the joint is really key in differentiating between septic arthritis and osteomyelitis. And the role of PCR is becoming increasingly important, especially for the lower virulence drugs like Kingella. CRP is really valuable, not only the absolute numbers, but the rate of change, apart from the more standard tests. Certainly, X-rays are useful, but in the early stages, they're often normal, and ultrasound and MRI are really key. And in children, we rarely do CT scans because of the radiation. Often MRI gives you all the information that you need. And then finally, we need to start the antibiotics early. We need to reduce the bacterial loads, often by interventional radiology, but sometimes by surgery too. And there are certain principles which we keep in mind as orthopedic surgeons when we are treating these. Thank you very much.